All right, welcome. Hi, everyone. Welcome to the Cambia Grove Trails Competition finale. We are thrilled to have you all joining us for today's event, and we are just so excited to showcase the 5 companies that have done an incredible job in focusing on solutions around improving the care of seriously ill people and their families. My name is Maura Little. I am the Executive Director of Cambia Grove, a healthcare innovation hub focused on advancing impactful innovation. And as I mentioned before, our Trails competition this year sought solutions to improve the care of seriously ill people and their families. Today, we will hear from 5 startups as they pitch live to our incredible panel of judges. These 5 startups have emerged as the top companies across the country, and the winner will receive an individual and personalized 3-month accelerator program through Bannister Advisors. We are thrilled to be partnering with Bannister Advisors, and we have Vanessa here to talk a little bit more about Bannister Advisors and what the Trails competition means to her and her team. Vanessa, how are you doing?
I'm doing really well. I'm broadcasting live from North Seattle and happy to be here. And like you, I so share the excitement to see these 5 incredible companies pitch their solutions. And, you know, I think it's been a journey to get to here. And from the moment the applications started coming in until now, we've been on the edge of our seat to get to today. So thank you for this opportunity. So I just want to take a few moments, like Maura said, to tell you a little bit more about my organization, Bannister Advisors, and what this competition means to us and how excited we are to partner, as she mentioned, in the customized accelerator starting this winter. So to start with Bannister Advisors, I founded Bannister Advisors about 3 years ago in response to some very critical life events that occurred for me and my family. Bannister is actually the middle name of my late father-in-law, Jay Bannister Laughlin, who is not only an incredible man, father really to me, not just father-in-law, but incredible grandfather to my grandchildren, or to my children rather, and also served the community as a social worker and psychotherapist. Jay unfortunately died due to complications from a rare type of cancer when he has just turned 65 years old, far too soon. And I know that I'm not alone in the audience with people who have been touched by cancer and the death of a loved one, the loss of a loved one. So palliative care, as you can imagine, is incredibly close to my heart and incredibly close to our mission at Bannister Advisors. Bannister is a team of licensed independent clinical social workers who do a type of private support to outside the healthcare system, mind you, for individuals who are facing critical and overwhelming lifespan circumstances, and those are often healthcare related. Sometimes they deal with a chronic illness, sometimes it's more an acute diagnosis, and definitely into complex elder care, aging, end of life, and even through bereavement after loss. We are in an incredibly privileged position to help guide the individuals, to help support their families as they work through whatever their particular experience is going to look like. With that privileged position, we have a unique view on palliative care and really focus it, as we do with all of our work and the services we provide, to focus on the individual, to focus on options. When somebody gets a diagnosis, again, in their family, or again, just as part of the aging process, whatever they might have the need for palliative care, the curative aspect of managing their disease often feels very out of control. So when we talk about options in the context of palliative care, it's also about bringing a sense of, you know, as much as possible, a sense of control and agency back into that process. Now, when we talk about, again, focusing on the individual and focusing on options, that's the link that makes me so excited for this competition, and not only for the 5 finalists, but for all the incredible organizations that just even applied. Because what that tells me is that, and my team, is it gives us a lot of hope about what the future of palliative care looks like. Because we know it's never going to be about one solution or one way that's going to be the right option for every individual and their family members. We, as people who are creating solutions, we cannot predict what is going to be the right fit for someone. We can listen, we can observe, and we can respond with inclusive solutions that address diverse needs. People aren't always going to even demand or ask for the solution that's going to work right for them, but they do continue to have those needs. And so the larger the buffet, so to speak, for them to choose from to fill their plate, the better. So with that in mind, I'm again super excited to not only see who the winner is, but we're ready to get to work. We're ready for our team. A majority of our team is going to actually be able to participate in the process, as well as the extended network of contributors that are going to be part of the accelerator program that's really focused on how to take the current solution and from the winner of this competition and enhance it further with a lens of social justice, equity, diversity, inclusion, and for us, representation. So with that, I'd like to turn it back to Maura. And again, thank you. I hope the excitement is coming through my webcam because we just can't wait to see at the end of today and where we go from here. So thank you.
Vanessa, thank you. Thank you. Thank your team. We are thrilled to partner with you on this competition, and overall, thank you for your work.
Thank you.
It's truly incredible. Okay, so now it is time for me to introduce our incredible panel of judges. Judges, would you please share your camera? We have a remarkable panel of judges. Many of them come from the 5 points of healthcare: payer, provider, purchaser, patient, and policymaker. We also have ecosystem leaders in terms of venture capital and ecosystem builders, truly, for our judges. These judges have helped us get the word out throughout this competition. And the rounds of judging actually have been pretty incredible. We started this year with a round of patient judges to make sure that as we look towards the future of who would be winning this competition, that patients got their voice in there first, so that we have it be more person focused. I am going to go ahead and let each of our judges introduce themselves, starting with John Kim. John?
Hello, everyone, and thank you so much for the opportunity to participate in this exciting competition. I'm the Executive Director of Pacific Hospital Preservation and Development Authority, where we invest in community-led solutions on addressing disparities of access to healthcare and disparities in health outcomes. But I have a long history in healthcare, working as a hospital executive and an attorney in private practice. I first became familiar with palliative care working with pain specialists in a community hospital setting that were working in one of the only inpatient hospice units in the state. But more recently, I've had the opportunity to work with palliative care specialists in the care of my father and my father-in-law, both of whom chose hospice for their cancer, the course of their cancer. And so I'm so excited to be part of this effort to really breathe some hard life, into innovations into this space, because it's an area that is so important to the whole notion of wellness and how to live beautifully. Thank you.
John, thank you. Thank you for joining us. Next up, Peggy Mcguire. Peggy, before you start, Peggy is part of Cambia Health Solutions, so their Senior VP, President of the Cambia Health Foundation, Senior VP Corporate Social Responsibility and Palliative Care Solutions. She has been instrumental in Cambia Grove's work in this space. And Peggy, just thank you so much for your time. Peggy?
Thanks, Maura, and thanks, Riley, and everyone at Cambia Grove for hosting this trails competition. I think, as Maura said, I'm the president of the Cambia Health Foundation, which has invested over $46 million over the past decade to advance palliative care, quality, access, and awareness. We have a program called the Sojourn Scholar Leadership Program, which is designed to identify, cultivate, and advance the next generation of palliative care leaders. And really just personally and professionally so committed to this work. I loved reading your proposals or your submissions, and I really look forward to the presentations today. This work is incredibly important and innovation is greatly needed. So thanks everyone for your time today, and thanks for inviting me to be part of the judging panel.
Thank you, Peggy. Okay, next up, Dr. Dominic Moore, the Associate Medical Director of Palliative Care from Intermountain Healthcare. Dr. Moore?
Thank you so much for having me, and I apologize if the image isn't great, but I'm very thankful and have been a beneficiary of the support from the Cambia Foundation. I admire Peggy and her team and the work that they've done, and have seen the way that those millions of dollars have been broken up to smaller seeds that were planted in many different areas, including Utah, where I work. I'm the medical director for palliative care within Intermountain Healthcare. We're a nonprofit health system that covers throughout the Intermountain West. And we are focused on making sure that everyone lives the best life possible. And that includes having the best serious illness experience that's possible. We serve large areas of rural communities. And so part of what I work on and what I have been listening to and paying attention to this year is the way that those communities are impacted, not just our large cities, but the small communities, and the way that that access can be improved. But I'm so grateful for the panel innovations that are to come.
All right, thank you. And I'm just getting texts from my team saying, okay, come on, Maura, hurry it up a little bit. I could say so many good things about all of you. So I will stick to the basics and turn it over to Dr. Mary Kay O'Neill, who's a senior consultant at Mercer.
Well, thanks so much, Maura. So I'm a Seattle native. I am trained at University of Washington, and my specialty in medicine is in physical medicine rehabilitation. So I have sort of out of the gate taken a view of helping people who are either have been catastrophically injured or have gone through or have diagnoses like neurodegenerative diseases, which have a progression. And so one of my passions from the beginning of my clinical work has been to make sure people who are frequently interacting with the healthcare system have a voice, and that it's heard, and that they get the care that is meaningful to them, that they have the support system that is meaningful to them, accessible in the healthcare setting. And subsequent to my clinical practice in running a large PM&R department at Virginia Mason Medical Center, I have worked for the state of Washington as a medical director for state employees. I've been a chief medical officer for health plans, and now in my consulting role at Mercer, I'm working with employers regarding having the best services available to their employees and their dependents. So I am really looking at, just like Maura said, service that facilitates an individual having a say, not just end of life, not just hospice care, but as they go into an intensive care episode, which for some people lasts their whole lives, that they are heard, recognized, that they are in essence driving the show with, you know, really great clinical advisors and input. But so I'm excited to hear about what everybody has planned.
Fantastic, thank you. All right, Matt Parmet, Associate, Echo Health Ventures. Matt.
Thanks, Maura. So I'm Matt Parmet. I'm an investor with Echo Health Ventures based in Seattle. Echo is a healthcare-focused venture capital fund that really invests on behalf of Cambia as well as Blue Cross of North Carolina to try to be a capital partner as well as a strategic thought partner to companies that are developing solutions to lower costs, increase quality of care, and most importantly, enhance patient experience and the experience of their families and caregivers. So we know there's a lot of innovation happening in the caregiver support and palliative care space, and we're really excited to meet everyone and hear from the finalists.
Fantastic, thank you. All right, Marianne Sarsich, our patient leader.
Hi, thank you for having me. I'm really thrilled to be here. So I am a breast cancer survivor and advocate, and I have been advocating in the breast cancer arena for a number of years. And earlier this year, I took all of those advocacy skills and I transferred them into the supportive care arena. And my goal is to help bridge the gaps that are existing right now that keep patients from receiving supportive care. And the ultimate intention is to have any patient who deserves to be supported by it receive supportive care as early as diagnosis, because research studies have shown that it will not just change the quality of their life significantly, but it'll increase the efficacy of those FDA curative treatments that they are receiving, and in some cases even extend their lives. And what I love about supportive care is that it encompasses not just the patient but the family. So it's really an incredible layer of care to be adding on, and I want to see that happen more. So thank you for having me.
Thank you, Marianne. All right, and Dr. Emily Transu, the Associate Medical Director for the Washington State Healthcare Authority.
Hi, it's hard to go after Marianne because she sort of said everything that needs saying. I am an internal medicine physician, also trained at the University of Washington's residency, practiced primary care for about 15 years and still do a little bit of that. So I've had many, many experiences of palliative care as a physician and also going through experiences with a variety of family members. So I have very many strong feelings about the importance of this topic. I'm now a medical director at the Washington State Healthcare Authority, which oversees Medicaid and public and school employee benefits. So we have a really deep engagement with palliative care in a number of populations, including rural and urban populations, employed folks, also many of the most vulnerable folks in our state in one way or another who are on Medicaid. So really, really honored to be here today.
Thank you. So as you can see, we have an incredible group of judges joining us today. A couple of things about what we are up to in the next, 75 minutes. So each team will have a 5-minute live pitch to our judging panel. The judging panel will then have 10 minutes of Q&A for each of those teams. I will call each team up in alphabetical order, starting with Asha AI, and then we will go ahead and move forward with that 5-minute pitch, 10 minutes of Q&A. If at any time, just in what traditional live pitches, there normally is a bell or a buzzer. Today, I have a cowbell. So if I need to get someone's attention, I will ring this cowbell. I did steal it from my children, so hopefully they don't come busting in. So is everybody ready? 5-minute pitch, 10-minute Q&A? All right. First up, we have Asha AI. Come on board.
Wonderful. I'm very happy to be here. Give me just 1 second. I'm in the process of figuring out how to share my screen here.
Fantastic. I will start.
I don't know if there's an option to do that. Let's see. Yeah, it doesn't look like there's an option to actually share screen.
I will start your clock once the option is figured out, and I'm sure Riley is behind the scenes working to get that figured out.
Can you keystroke Alt-S to pull that up?
There might
I'm on
be.
a iPad.
Oh,
Do you see the green share button at the bottom of the screen?
I do. I mean, there's options to share photos, iCloud Drive, Dropbox, everything but your screen.
Strange. Okay.
Let's
You know
see.
what we might do? Let's give it 30 more seconds to see if we can figure it out. But in the interest of time and our live pitch, we might go to carrying ALS first and then get back to Asha.
Sure. I can try Google Drive. Let's see if that works. Are you able to see my screen?
No, not
yet.
yet.
Hey, Rashmi, I can share our video for us. I mean, our deck.
Yeah, that'd be great. Thanks, Dayton.
Oh, perfect. All right, and I can see everything. So let's go ahead and start in 3, 2, 1.
you're on mute.
Oops.
Hi, my name is Rashmi Joshi, and I'm the CEO and founder of Asha AI, a remote elder care solution. Taking care of aging parents is hard when you're not nearby. Let Asha help. Asha, or hope in Sanskrit, is also the name of my grandmother. While my grandmother battled cancer in India, the rest of my family battled the difficult question of how to manage her health without being physically present. Our connected world and an aging population require a holistic health management solution that centers on keeping families connected to each other and to care. As people age, their health declines, and the need for care increases alongside multimorbidity. This problem is made more complex as many caregiving adult children live apart from their aging parents and have very limited ways to help them manage care. Many patients can't afford professional caregiving services and are left with very few options on how to manage their own care while aging in place. Remote care solutions that are on the market today require users to be tech savvy to use them, which is difficult for most elders, and those with accessibility issues such as problems with their vision, hearing, mobility, or even fine motor skills. Additionally, many palliative care solutions today are focused on maintaining lifestyle rather than preventing decline. Asha is the only fully accessible remote care solution because you use it through simple oral conversation. Elderly patients and others can receive reminders on when to take certain medications, their upcoming medical appointments, or order a variety of wellness services, all through simple audio commands. On the other hand, caregiving children receive alerts and notifications on the health of their parents and family members and can rest easy knowing that EMR services are auto-dialed in case of emergencies. Additionally, users can connect easily to a variety of IoT devices for condition-specific health monitoring. Asha serves as a central aggregate and learning personal health record for each patient with an EHR integration on our product roadmap to effectively tackle fragmented care coordination. Asha's around-the-clock monitoring and qualitative conversational analysis detects anomalies for speedy access to care that helps prevent decline and effectively manages population health. As numerous studies have indicated, social support is hugely impactful on patient health. Asha checks in on patients multiple times a day and can be used to audio or video call care team members, increasing access to care, or loved ones, all without needing to learn how to use any new technology and remaining independent. At only $30 per month per family, Asha is much cheaper than professional caregiving services and accessible to most in the US through a simple mobile device with the option to integrate with Amazon's Echo. We plan to expand to other geographical regions and language-speaking groups and also partner with nonprofits to make Asha available to anyone who can't afford it. Asha is fire operable, HIPAA compliant, patent pending, and doesn't require FDA clearance. It's accessible to caregiving children, as well as employers and payers as a monthly subscription. We reach our customers through condition-specific partner marketing campaigns to help educate caregivers and patients on how to best manage care at home. And we partner with nonprofits, IoT devices, and wellness services. We are currently raising our $350,000 SAFE as our pre-seed round, with $100,000 already secured, and plan to use the funds to build out our MVP and do a pilot program with Avaho and the Alzheimer's Association. ASHA's core team is comprised of a group of serial entrepreneurs, technologists, physicians, and healthcare experts with over a century worth of combined industry knowledge. We also have a diverse group of medical and technical advisors with particular focus on geriatric medicine and healthcare AI. Join us in creating positive outcomes for the elderly. Thank you.
All right. Now we are looking, is Rashmi still on? There you are.
I'm here.
All right, judges, questions for Rashmi.
Rashmi, how does this device interact with people who are deaf or hard of hearing?
So number one is they can also access it through the mobile device. So they can type in answers and receive questions through the actual device, as well as integrating with Alexa. So for people who are hard of hearing, they can interact solely through IoT devices, if that's what they prefer, or they can use their mobile device, or they can use the Alexa and turn the volume up.
Thank you.
Thank you.
Can you give a few more examples of what concretely, what sort of information would be being passed back and forth? So the examples on the screen showed things like being due for a medication dose or an appointment, but tell us a little bit more about kind of what actual content would be moving back and forth.
Mm-hmm. So the first piece is helping with medication compliance. So we keep track of when patients have to take certain medications throughout the day and send them reminders. And we also check in with them to make sure that they're actually taking those medications at the time that they're supposed to. If for whatever reason a patient has a particularly difficult time doing this, then they can use something similar to a smart pill box, which is part of our product roadmap in terms of our IoT integrations pipeline. So that's one of the use cases associated with ASHA. Another use case is making calendar appointments. So say, for example, a patient has some symptoms related to a particular medical condition. Let's say they have a headache and they're a dementia patient. They can say, hey, Asha, I have a headache today and I'm not really sure what to do. And Asha can triage them appropriately by calling their either a specialist or their PCP. So they can initiate a call to the neurologist and have them make a calendar appointment. And the patient can then either manually add it in through their mobile app, or they can ask Asha to add it through a audio command. So that would be another piece of data that Asha could actually implement into our platform. We also keep track of a variety of different IoT devices that are condition specific. So this could be something similar to, say, a blood glucose monitor for diabetes monitoring. It could be more general, such as the Amazon Halo, which has a variety of different data points that it monitors. And we take all of this data gathered for each patient and we digest it and bring attention to facets that could help prevent decline and communicate them in a easily digestible visual format through the application and obviously through observing HIPAA consent protocols with caregivers as needed. I hope that answers your question.
So this is Mary Kay O'Neill. Could you describe a little bit more about the social interaction part of it? You've got the technical part that you just described, and if you would, how you modify that for people with different cultural backgrounds and preferences.
So socially speaking, that's actually one of our biggest drawing points for ASHA, is that this is not a solution that's made solely for people who are trying to stay in touch with their families. For example, there are plenty of people who are living at home independently and are either battling very serious illnesses or are aging in place, and they may not have family members who are there to check in on them 24/7. So ASHA actually serves as kind of a health concierge at home and checks in on the patient several times a day to see how they're feeling, as well as helping them keep track of at-home care, which includes some of the medication compliance reminders that I mentioned. And then later on, as part of our roadmap, we're implementing things like brain health games. So people can play brain health games with ASHA to help prevent decline for dementia patients, for example, or nutrition and exercise reminders. And the other aspect of our platform is that we have a suite of different wellness services that people can order through ASHA through audio command. So at the time, if they actually need other kinds of care, so this could be something like laundry, this could be related to, say, meal planning, chiropractic care. Let's say they need professional caregiving services, but only for a couple hours a week. They can actually order all of these services through ASHA's platform, simply through oral conversation. So say, for example, there's an elderly patient or someone who is bedridden, and they have a hard time getting up to check their devices. And for that reason aren't able to use apps like Zoom or apps like Uber or Lyft to be able to get from point A to point B to all of their appointments. They can actually place orders for all of those services through ASHA, through our API, through just an oral command. And so in that fashion, there's a variety of different use cases that we don't actually provide ourselves, but we leverage our external third-party partners, including IoT devices and wearable services, to be able to expand just how many different things, different use cases patients can have access to solving through ASHA.
Thank you.
Thank you.
Rashmi, that was a really lovely presentation, and this is such a cool project. Could you say a little bit about kind of the minimum functional status that a person could have to engage with ASHA in their home, as far as cognition and verbalizing?
Yeah. So the first portion of that is, we do help focus on dementia care, but we're focused on the first phase. So if we're dividing the dementia journey up into, say, 3 phases, we're really focused on adding value to that first phase when a person is still, for the most part, able to take care of themselves, meaning they're able to get up, get around, they're able to do things like brushing their teeth, with, as many of us know, in later parts of the dementia journey, people even have a hard time remembering how to do these smaller tasks that we all take for granted these days. So what we focus on is helping prevent decline within that first phase when someone is still living independently at home and, for the most part, able to take care of themselves, but is looking for a little bit of help sort of managing their day-to-day routine. And sorry, there was a second part of that question as well. Can you remind me what that was?
Oh, I think you answered overall. It was kind of what's the minimum level of functioning that a person can have and still be engaged with ASHA AI.
Mm-hmm. Yeah, and obviously the second part of that is they're either able to use the mobile app, meaning they have some dexterity in terms of fine motor skills, or they're able to engage through oral conversation. So once people actually get to the point where they start forgetting languages, etc., then that's when ASHA stops being useful, and they're moved into more specific care, such as long-term care facilities.
We have 3 more minutes. Marianne, you've been off mute.
Yes, yes. So I'm wondering how your service, or if it does, integrate with a patient's care team, because a lot of the burden that falls on the patient and the family is coordinating everything and understanding what in the world that was just said to them. So how involved are you with the clinicians that are caring for that patient?
That's a great question. So to begin with, we're starting out with our care directory. So we have a care directory as part of the ASHA platform. So every patient and caregiver can access that, and that has very basic information such as the name of all of their care providers, their pharmacy, the phone number and or email associated with those, as well as the address. And we store that information so that we're able to call them as needed based on what's actually happening with the health of that patient in real time. So they're not having to keep track of, in their little black book when they're looking for their PCP, how to get in touch with them. So we're starting with that as our baseline functionality, and then we're adding on from there. Obviously, right now we're very focused on at-home care, and we're focused on adding operational value rather than clinical value. But later on, what we plan to do is create a provider portal through which we can actually display our predictions and meaningful insights about the patient to any member of their care team in a HIPAA compliant and FHIR operable way.
This is Peggy. How did you develop your pricing model?
So we chatted with approximately, I want to say about 50 different families, including both caregivers as well as patients. And we did thorough surveys of all of them to try to understand what their pain points were. And during that time, one of the core questions that we asked was, how comfortable would you be for paying for this, number one? Is this something that you would pay for? And then if so, how much would you pay for it? So the pricing was determined through these user surveys.
Thank you.
Thank you.
Question
Matt,
about
if you quick one.
Yeah.
We are out of time. Matt, do you have a quick one?
I was going to ask you, Rashmi, to just elaborate on the plan to commercialize with employers and payers, if you have a quick answer for that.
Quick one.
Yeah, absolutely. So we're launching with B2C for caregiving children and patients. And then we're actually partnering up, we're distributing to employers via HR brokers and offering them commission to do direct sales later on with payers. And we've got a fair few payers who are actually already interested. We're chatting right now with Devoted Health. One of our advisors sold iTriage to Aetna. So we've got a fair bit of our pipeline built out.
Great, thanks.
All right. Thank you. Thank you so much.
Thank you.
Okay. Next up is Caring ALS. Why don't you go ahead and share your deck, and I'll start the clock once you're ready.
Okay. Share.
All right.
View.
Ready? 1, 2. Wait, it's not. Okay. Ready? 1, 2, 3, go.
Hello, everyone. My name is Mrgesh Nawar. I'm the founder of Caring ALS. We make healthcare affordable by bringing together a larger community to help pay medically related bills and expenses. And we make care more accessible from anywhere through our telehealth service. Our initial focus is ALS. Let me tell you a little bit about ALS. The first symptoms usually show up as fatigue, poor balance, slurred words, other such minor symptoms. Could happen to anybody. When the symptoms persist, a patient may start to suspect ALS, but the primary doctor may not be ready to refer them to a neurologist. And the neurologist then goes through their process before an official diagnosis of ALS can happen. Now, 17 months have passed on average at this point. And the patients usually die 2 to 3 years within diagnosis. Throughout this process, the patients and their families are often lurching from one crisis to another with no roadmap, no advice, no money, and no treatment. This is an incurable disease. While early treatment may help slow progression and improve quality of life, financial stress makes many people avoid seeking the treatment they need. An average person with ALS spends $15,000 per year out of pocket. Many seek experimental or alternative treatments that end up in the six figures. ALS is an expensive disease. The good news is that Americans are quite charitable when it comes to medical bills. 1 in 5 American adults have donated to help pay for medical bills and treatment for friends, family, acquaintances, and even strangers, as you can see here. Our platform is super simple to use. Our user simply uploads bills or estimates, and the bills are paid on their behalf by donors. When a bill comes into our system, it's immediately transformed into a funding page to which donors and sponsors contribute. Now, every donation from friends and family is matched with donations from corporate partners. So this is a community of folks helping pay the bill. And before a bill is paid, it is processed through our machine learning algorithms model to detect fraud, abuse, and errors. You know, it is estimated that 50% of medical bills have errors. Recently, there's a New York Times article that you might have read that was a survey. It showed insurance companies have been billed and paid between $80 to $8,000 for each COVID test. They paid it. So when these bills come in, it's not that there isn't information in these bills. On the contrary, there's too much confusing, confounding information. So instead of using a human expert, we have developed an AI model to sift through their data and flag each billing item. As far as access is concerned, in many parts of the country, there's not even a neurologist that people can access. So we are making it really easy by bringing a diverse set of care providers to offer easy telehealth appointments. As more provider bills are added to our system, those providers we expect will become will offer teleconsult to our patients. Many people compare our system to GoFundMe, and I want to point out, this is not a crowdfunding platform. We are a direct payment system where friends, family, coworkers, neighbors can discreetly send their contributions directly to the care providers. We're part of the patient community with matching funds raised from corporate partners and philanthropic partners. Our service is seamless, and we're not a middleman. We do not touch the money. Who built this? My sister Indu is also a software entrepreneur and a former investment banker. We embarked on this venture together after the death of her husband, Peter Cohen, to ALS last year. Our product team is complemented by a large and wonderful team of collaborators in the form of patient advocates and highly motivated student interns. And we're collaborating with the major research institutions in America, Mass General, Harvard, Johns Hopkins, et cetera, to bring this together. But as you can see here from this chart, since 2007, middle-class American families are paying more for healthcare while paying less for food, transportation, shelter, clothing, et cetera. So the need for our service clearly expands beyond ALS. Thank you.
Wow, great job. You got in within 1 second. It was 5 minutes.
Wanted to use it all up.
All right, 10 minutes Q&A. Peggy?
Yes, thank you so much for that presentation. I love that you were talking about reducing the financial stress of serious illness, because we know that's a great burden for both the patient and the caregivers. Have you thought about, in future iterations of this, actually identifying ways to reduce the overall cost instead of just paying the bill?
Yes, that's exactly what's going to happen, because there's a larger movement than us to bring over more transparency in medical billing. I think from starting January, hospitals have to list at least 300 of their treatments, including their negotiated contract rates with insurance companies, publicly on their website. Let's see if they will. There's a lot of pushback on that. They lost the court case. So what we do is we get all of this data and we can look on an individual item by item basis and flag these things, what the fair price should have been for that particular service. And I think will help in this process of kind of normalizing all the costs down to a fair market value, if you will.
Great. Thank you.
So I'm wondering, how would a patient know about you? Are you pushing out into social workers, for instance, or clinicians so that, you know, once a provider realizes that this family is having some financial toxicity, they would recommend that the patient's family look into using your platform?
Yeah, so we started a nonprofit called Everything ALS. We're partnered with it, and Everything ALS has webinars every 2 weeks with the top researchers. And we have 400 or 500 patients join these webinars every other week. So ALS is a very small community, thankfully in many ways, but they're all aware of what we're trying to do right now. So we want to start helping ALS patients, and then we can go transplant this model across other rare diseases.
I'm interested in how you differentiate between effective treatments and treatments that may not be effective in this kind of state where there are really no great treatments out there. How would you make sure that you were funding things that were appropriate rather than things that might sort of offer false or unsubstantiated hope to folks?
That's a great question, right? What ALS really needs, or any disease where there isn't a standard of care, is diversity of treatments, right? But how do you thread between quality of care and diversity of treatment? That's a bit of an art as much as a science. So we are a for patient, by the patients, for the patients type of platform. So we get a lot of patient wisdom, if you will, to go into sorting out the providers who should be on the platform and those that should not. But generally speaking, we're working with we're starting out with very qualified providers whose the only issue there is not their qualification, but the cost of their service. And eventually we'll broaden it out to functional medicine doctors, naturopaths, et cetera, who can really, really make a difference in this space, but conventional medicine cannot.
So I have a couple of questions. The first being, having an AI process going through complex medical billing and identifying errors sounds like a decent thing to do, but then how do you help the individual with the billing error, or is it on them to run the process with the carrier?
Well, since we are good at providing matching funds, we have a right to a fair bill. So we will build those relations with the providers that, because we are raising funds and we're co-investing, or if you will, into that bill, co-funding that bill alongside the patient's community. So once we find it, we will go and redo the bill and come to a fair negotiated settlement with every provider.
Oh, you're doing it with the provider. So the billing errors are, the billing and payment errors are often adjudicated by the insurance companies. So you're not dealing with them. Is that
well, the insurance companies tell us, Aetna tells me that 50 to 70% of the bills they believe are fraud or abuse. That's what they believe. So in that sense, they're being great partners to us. Eventually, when we find something, we'll work with them, through them. So it's a win-win for everybody at this point. Except for the ones that do not want transparency.
Yeah. So, and you had an impressive list of people doing part of the funding for the outstanding aspect of the bills. Are those organizations making a kind of commitment over a time frame? I mean, how this is, and as you get into more disease states, the figure will obviously go up unless we solve the pricing problem.
Right. That's a great question, because we're starting out, we've spoken to a lot of corporate partners already, but it turns out the easiest way for us to do it is to just get onto their gifting programs. They already have that to nonprofits. So we do the matching gifting. So we amplify whatever gift any employees can provide. We'll go into this nonprofit, and this profit matches every dollar for dollar or some percentage of the dollar that's contributed by the patient's ecosystem. And that bill is then processed and paid to the providers.
Okay.
I understand that you use platform fees to pay for the payment side of the service, but how do you pay for the assembling the team of specialists especially if it's something that occurs across state lines, across, large distance?
Yeah, fantastic question. So essentially, we are embedding telehealth options, integrating into their calendar with these providers. So our patients can go in and assemble. It's a multidisciplinary care. They can assemble the people that they need. First of all, they can sort through these providers to see who's a good fit for them. There's a lot of reviews and feedback from other patients. Very standardized education material, consolidated education across all these providers. We'll interview each of these providers in a very consistent way, and patients can decide who the right partner for them are. And what we're trying to do is get integrated into their calendar so patients can book with them. And the pricing is going to be upfront, right? What the pricing is. So it can be post-paid service, post-service payment. It's also pre-service payment where these people take money upfront and then they provide the service.
Thank you.
Got 3.5 minutes left. Any other questions?
Yeah, this is Matt. I guess maybe this is more of a vision question, but because you're focused on rare diseases such as ALS, do you see any opportunities to kind of create a community around patients that are using your services so patients can support other patients or learn from the experiences of others, and realizing that might be kind of farther down the road, but just curious your thoughts on that.
Yeah, thank you, Matt, for asking that question. Yes, we started with ALS, and we formed a very unique type of nonprofit, if you will, because most nonprofits around other diseases, most diseases are patient advocacy groups. They do not bring software and technology into play. So we see ourselves working with pancreatic cancer. There are a lot of these advocacy groups, right? They've got communities of patients. They can replicate exactly what this model is, essentially. It'd be very lightweight for the caring ALS, caring pancreatic cancer, all of these things, basically.
Mrgesh, that was excellent. Could you say a little bit more about when you start the chart review? Often, as you know, some of these folks who are being worked up for ALS have kind of been an undiagnosed medical mystery to people for some time. And so do you go like 6 months prior to the diagnosis, or how do you choose your time frame for the AI to go in and do the charge review?
Yeah, so, this is a hard area of research actually at this point. How do you get people to be diagnosed sooner, right? That's the key thing, because by the time they're diagnosed, maybe sometimes 80% of the motor neurons are gone, and it's hard to bring them back. And you can slow down the progression if you catch it early, like many other diseases. But there's this stigma of not wanting to admit that you have ALS. The primary doctors don't want to tell them this is ALS. The neurologists take their, so there's a lot of delay. But fact of the matter is, Dr. Google has already told them that they have ALS. They know it many a time, right? So what we are trying to figure out is how do you give them hazard score so they can input a bunch of data. In fact, there's a researcher at Microsoft, he's looking at your web history, your browsing history on the website, and be able to come up with a hazard score and say you likely have ALS based on what you're looking at, what you've been searching, right? There's a lot of different ways to look at different types of data, including maybe taking the voice samples over a period of time and seeing the degradation, having AI kind of tell you what this may be. Those are things not that we're building, but we'll partner with companies like that can actually provide a hazard score upfront for people who may not even know, who may not even have been officially diagnosed yet, to get them to official diagnosis sooner.
Just under 1 minute. Any last quick questions?
What if the patient has no friends or families who have financial capability to chip in?
Yes, typically we've got a couple of variables. We've got the matching component, and we've got another component, which is every bill will provide a certain amount upfront from this pool. So we can probably vary that. We haven't come to that, but we do have people, not just they don't have friends and family, but they don't want to tell their friends and family that they have ALS yet, but they still need help, right? So we're still working through the modalities. It's a huge psychological issue that we need to go very gently. The main thing we want to do is it's not you, it's we, us. We're together going to raise funds to pay this, not you. So getting the we in there is the most important, probably the essential element of what we're doing, how we're different.
All right. Thank you so much for your work.
Thank you.
Next up, we have community collaboratory. I said that a couple of times, but that was, was hard. All right, Aaron.
You got it.
Go ahead and share your screen. Fantastic questions, by the way, all the judges. All right.
Okay.
Ready? 1, 2, 3, go.
All right. Thank you so much for the opportunity to be here, everyone. My name is Aaron Flaster, and I'm the founder and director of Community Collaboratory.
And my name is Sarah Stackpool. I am the medical and palliative advisor. And just really briefly, I'd like to speed lead you through this concept that we use sometimes in palliative care called the empty chair. I'd like you to close your eyes and think of someone you know who may not have a lot of resources or available support, be that a neighbor, a student, or an elderly acquaintance. And now I'd like you to think about them navigating daily life with a new life-limiting illness, let's say colon cancer. How will they get to their appointments or afford basic necessities? Who will advocate for them when there's something that they may not understand? How will they get their meals or do laundry after they've had a treatment and just can't get out of bed? And will they be lonely?
And as Sarah just emphasized, we really need to focus on palliative care patients that lack that social safety net, especially, as John said earlier, patients that may not have many friends and family who can help them with finances, or as Marianne emphasized, being able to coordinate services. And we really need to focus on palliative care patients in the community because, as we know, the majority of patients live at home. And so what we need to do is to increase access to social support and really be that liaison between patients and hospitals. And that's exactly what we're trying to do at Community Collaboratory, is really focus on poverty and equity, social determinants of health, and evidence-based practices for community-based palliative care. And specifically, we're doing that by trying to increase access to a network of community volunteers. So people like you and me who want to do something, want to offer support, and have skills to share, but don't have regular schedules and can't make the long-term commitments that many volunteer organizations require. And so what we're doing is developing the only website and app that allows patients to finally, easily, safely, and more flexibly create a network of volunteers to offer brief and ongoing support. And there have been other organizations that have tried to increase access to social support, but in talking to community members over the last few years, we kept hearing that it's still too difficult. And we really tried to investigate why is it so difficult still and what can we do to make it easier. And so these are some of the core features of our website and app that community members told us they want to see. They want to have a easy matching algorithm so they can search by zip code, age, topic for people that they want to offer or receive support from. They want to offer support alongside their friends and their spouse so that they are part of a team. They want supervision and training from trained staff if they have questions or don't know what to say to someone. And most importantly, they want to feel safe. But they don't want to feel safe at the expense of having really cumbersome onboarding requirements. You know, if someone told me, why should I have to pass 3 background checks to bring my neighbor some groceries? And we additionally want to connect with resources and platforms that patients are already using, whether that's GoFundMe or other resources. We want to integrate with what patients already use and are familiar with. And as I hinted at, we did really in-depth customer validation the past 2 years. And we started with 27 qualitative interviews with social workers, community members, mental health researchers, volunteer managers, really trying to identify the pain points of both patients and people that want to volunteer. And most recently, we launched a landing page to look at additional data like website traffic, and we found that in just 8 weeks, we had over 2,300 page views from over 21 countries. So just really highlighting the global interest in the solution that we're trying to come up with. And in addition to that, we had 112 people sign up as new customers, and the majority said, I want to use this website right now, and the other portion said, I'm really curious and want to learn more. And additionally, we had a survey on our landing page, and we had some really interesting data from about 104 people. And this data really confirmed our beliefs about the pain points of volunteers and what they want. And so we found that over 80% of people have an irregular schedule, which again, automatically rules out almost all traditional volunteering. People want to use both an app and a website. For millennials, for older adults, they want to have options. And they also really want that matching algorithm and to match locally. And additionally, we found that 65% of our survey respondents want to pay for a subscription. But we will always make this an optional subscription to prevent any pay barriers for community members. And in the long term, we want to work towards paid contracts with health insurance and hospitals and social service providers by showing we can reduce their costs. Our next step is to develop a minimum viable product. We have a couple of grants in. We just submitted an SBIR and a grant into the American Heart Association, which we hope to hear back from in February. And this is our fabulous team of health experts and researchers, legal marketing consultants, and web and app developers. And that's everything. Thank you.
All right, thank you. I almost had to use the cowbell, but that was perfect. Thank you. All right, let's go ahead and start our 10 minutes of Q&A.
Aaron, what's going to happen to you if the pandemic restrictions continue, deep into 2021? How does that timing sit with you and the availability and, availability of volunteers willing to step up and engage in this kind of volunteering through the platform?
Yeah, great question. So I think that is really highlighted by, let me jump to this slide, which really highlights, again, the difference between, so with traditional volunteering, like I looked up right now, palliative care volunteering in Seattle. And if we imagine someone who's receiving care at Seattle Cancer Care Alliance, they're not even taking volunteers right now because of COVID. So a lot of in-person volunteering has just stopped, which is really unfortunate because, as we know, a lot of volunteers are older adults with time on their hands. And so with COVID, what we would do is we're only going to launch with remote volunteering. So both so that we can keep people safe from COVID and so that we can really refine those safety protocols that I hinted at. I would say for about the first year, we will only allow remote volunteering. So that's things like sending supportive messages through our website and app to a patient, helping them coordinate services, dropping off groceries, but not interacting with them in person. So really, we'll still be able to be successful and allow volunteers to feel safe during COVID. So we're sort of planning for COVID to still be around for the next year and a half, 2 years.
So Aaron, this is Matt. One of the, so super interesting idea and presentation. With any two-sided marketplace, there's sort of a chicken and egg problem, which is how do you entice volunteers to sign up for the platform before a lot of folks are kind of demanding services, and vice versa? How do you get someone to go on and sign up to receive services before there are a lot of volunteers? So just curious how you're going to tackle that kind of bootstrapping issue.
Yes, perfect. As the investor, I was hoping you would ask about the two-sided market. So when that was, some of our customer validation data really helped us identify that target audience. So for the audience of offering support, the data really showed that middle-aged women, about 45 to 50 years old, Caucasian women living in Seattle are our target audience for volunteers offering support. And the way that we will try to attract people offering support is through referrals and partnerships with community-based organizations. So I've already started building a lot of relationships with trusted organizations in the community. So these are synagogues, churches, nonprofits, neighborhood associations. And a lot of them already have a version of their kind of own internal mutual aid network. So a number of churches said, yeah, we have something like that. When a congregation member needs something, they email me and I try to email someone else in the congregation. It's a disaster. And so we would love to use something like this. So we can see that there's interest in the community, even outside of palliative care, but that's the plan for that one side of the market. And then on the other side, again, partnering with hospitals, community-based palliative care providers and programs. And so in short, Matt, the short answer is relationship building. and really doing the hard work to build relationships with both sides of the offering and receiving support.
Great, thanks.
Yep.
Eric, thank you for the presentation. Really great concept. I love the idea of neighbor helping neighbor and facilitating that with a technology platform. A couple of questions. One is whether you're familiar with Papa Pals or other companies that are in this space trying to do similar things.
I am, yeah. So I can jump back to Caring Bridge is really one of the closest things that I've seen to our competitors. And this is I think I have a fuller list of competitors. So here are kind of the main competitors that are in this space. So Caring Bridge, MonoMe is a new one down in California, working with older adults in Los Angeles and San Francisco. TaskRabbit for Good, lots of helping hands. So again, we've really spent time digging into who else is in this space and what are we trying to do that's different. And again, the things that we're trying to do that are different are primarily offering that ability to match. So some community members have said, oh, you're kind of doing like a dating app for social services, which is sort of a weird, it still feels weird to say, but it is a way that distinguishes us from these competitors. So for example, on Caring Bridge, there's actually no way to search for someone in your neighborhood. So for example, my aunt has a Caring Bridge right now, but I have to know that I'm searching for my aunt, as opposed to I can't just look for someone in my zip code. Same thing with MonoMe. When you submit there saying you want to volunteer, they have staff members who are then trying to pair you with people that have submitted a form to receive support. So again, just like the churches where there's a real person and that's takes time, I want to be able to match with someone now in 5 minutes. And then with lots of helping hands, they also don't have, a lot of their posts are from previous years, a lot of them are outdated. So not to throw mud at the competitors, but I think this ability to easily match with people is really one thing we heard from patients and community members. And jumping back to,
while you're finding that slide, Erin, something that I would like to add to that is as a provider, what I love about this and that matching ability is that it gives power to the patients and it lets them be an active voice in choosing what they're receiving and what they're looking for and bringing in, which you don't always see in a lot of these other services.
This is a comment, not a question, but I could also see this having some application to caregivers and thinking about extending it to, respite care for caregivers, thinking about things like that.
Yeah, exactly. Wanting to take that burden, again, as Marianne was saying, off the family, the burden of service coordination, of just feeling burned out. And especially for people that may not know many other individuals in the city they live. And so what we want to do is to make it easy to find a network of people who can sign up for very specific tasks and additionally have those trained staff. So that's one of the other differentiators for us is we plan to have paid community health workers who can be on call and offer skills training and additional support. So when I did a presentation to a neighborhood group here in Seattle, they said, Erin, this app sounds great, but like, I thought you were going to teach us new skills. We really want to know, we don't know what to say to someone who is living with cancer or depression. We don't know what resources to point them towards. So again, you have a lot of well-intentioned people who need that direction. And that's where, and none of our competitors, they have staff support for like IT things with the website, but not a trained paraprofessional that you can call and help guide you. And I just want to say something quickly, Peggy, about the safety protocols. That's always people's first question is how are you going to keep patients and volunteers safe? And I think one thing that distinguishes us is this kind of tailored safety protocol and vetting. So right now with traditional volunteering, you have to do multiple it's really the gold standard. They really do keep people safe. But again, as a neighbor said to me, why should I have to pass 2 background checks to bring someone groceries? and drop them at their doorstep. So what we have is a system we're developing to tailor the amount of vetting to the type of task and involvement. So if you just want to drop off groceries, if you just want to send a supportive message through the app, you probably won't have to do much background vetting. If you want to support someone with a disability application, if you want to drive them somewhere, if you want to offer ongoing support, then we're going to start talking about background checks, in-person interviews, you know, car inspections, things like that. So that's one of the other things where we're really going to allow people to easily join as volunteers, but still keep people safe.
1 minute left.
May I ask about your strategies for diversity and inclusion for clients who may wish to have volunteers with shared cultural experience?
Yes, definitely. So the short answer is, again, relationships with trusted community organizations. So here in South Seattle, we have a really large Ethiopian population. And when I spoke with a community health worker at a hospital here in Seattle, she said, you know, oftentimes we have patients that speak Amharic and don't have anyone to help translate applications for them. And so what we want to be able to do is, another feature is private groups within our website. So churches and other community groups said, hey, what if we, as maybe the Ethiopian Community Center, we know each other, we have a small community, we want to be able to just have a private group, kind of like a Facebook page. Could that be a feature? And so that's, again, one of the examples of how we're really listening to community members for what they want and how we want to make this accessible to different languages, different abilities. So we have a community advisory board as well that I formed with disability service staff, patient advocates, and other social service professionals to make sure that we're building it as an accessible tool and that we then partner with organizations who would feel comfortable using it from different languages and cultures.
All right, we're at time. Marianne, I know that you lobbed a question in the chat. I will honor 15 seconds. What is your question, real quick?
Sorry, so my question is, how do you ensure that a patient doesn't get overwhelmed by asking for all these specific tasks to be helped with, and then having the patient be burdened with coordinating all the responses they're seeing on your platform and making sure that they, you know, engage with each volunteer separately? That to me could be overwhelming. Sorry.
Super quick, Aaron.
Is that okay? Yeah, so really quickly, the difference is that we will have really small teams of volunteers. So for example, on Caring Bridge, you can have 100 people. And like you said, Marianne, that can be overwhelming. You get responses, you don't know who's doing what. And they, to their credit, they do have kind of a core team of people that can coordinate those other volunteers. But for rapport, for efficiency of information sharing, we're only gonna have 6 to 8 people on a community care team of volunteers. And again, staff will be able to see all of the messaging between users and be able to offer support and facilitate that. So again, those community health working staff are really essential.
All right. Thank you, Aaron. Thank you, Sarah, for joining us. Okay, we are running a bit behind. Golden Sherpa, come on up. All right, and as Margie, as you get your slide deck pulled up. Again, we're gonna have 5 minutes pitch with a 10-minute Q&A. All right, Margie.
Can you see my deck?
We've got it.
Okay. Well, thank you. I'm so excited to be here today, part of the Cambia Grove trial competition. In 2014, I lost my mom to a rare
Margie,
yes?
I'm going to stop you real quick. We cannot see you advancing your deck.
Okay, okay. We'll just do it this way.
Apologies for interrupting. I didn't want you to get too far in though.
Can you see that?
Not yet.
Can you see that? Are we advancing?
We're not seeing your deck anymore.
Okie doke.
We saw your deck, but it didn't translate, or it wasn't at PowerPoint slideshow.
We're gonna try this one. Can you see my deck? Are you able to see my deck now?
Not yet.
Okie doke. Manish, I have you on the other line.
Yeah, I'll put it on my.
That's so crazy. I have this, everything.
Here we go.
You're on.
We're ready.
Well, thank you for helping us to get that figured out. Golden Sherpa. We, in 2014, I lost my mom to a rare reoccurring cancer, and I was beside myself. My dad was across the country. I live in Washington State, my sister's in California, and my brother, he's in the DC area. We're all over the place. I couldn't even focus on work. I was so worried because I wasn't sure what Dad was going to do. You know, you're never taught how to care for your parents in their golden years. And suddenly, I was in crisis. I went online, but I couldn't find information that was going to help me. I had searched for a home online. I'd even bought a car online, but this was my father. I was looking for a new way of life for him. I needed to know that he was being cared for. When I start thinking about this, I was reminded of when I had my children in daycare. You know, I had them in excellent daycare. I didn't worry about them while I was at work. But this was my father, and it was different. I needed help. And I saw that there was something missing in the senior living community. So I created my company, Golden Sherpa. With Golden Sherpa, we match people looking for available placement in senior residential care and in palliative care. Today, so many families have few options. If you're a user looking for information about senior living, you can go to a free referral website, but you know, you're selling your information. That's how you pay them, with your parent or your grandparents' information. You can do it yourself, but of course that takes a lot of time and you may not have the expertise. You can talk to your friends and family, but again, all of these take time and none of them tell you what is available in the senior living space. Providers, they're doing the exact same thing. They actually purchase your information from referral companies. A small adult family home in the Spokane area can spend around $20,000 in just referral fees. When they're looking for leads, they also network locally. And of course, if a friend and family referral calls them, they're going to get on the phone and try to educate them about their product and service. With Golden Sherpa, the problem that we solve is senior living communities spend thousands of dollars and resources to find leads to fill their empty beds. Our solution is simple for the user and for the community. If you're a community, you can show your information about your availability in real time, at any time, every day. As a community, you also reduce cost. We help you to reduce cost while maintaining quality care because we charge a low monthly subscription fee for our service. Today, if you wanted to give a tour in your adult family home, you could do it through our virtual tour. And if you're a community, if you're a user, adult child, social worker, nonprofit, you can search by criteria that's important to you. We have information about the community's care level, how you can pay them financially, and of course, all the details and photos to look into the community. And when you make a decision where you want to take a tour, you can do that virtually through the Golden Sherpa portal. There are over 3 million beds in this $19 billion market. We started Golden Sherpa in the Spokane market in 2019. I have an amazing team helping me develop Golden Sherpa. Today I have with me Manish Basali, our CTO. He was a co-founder for Realtor.com. And I want to tell you, each one of us, we've experienced looking for information for our own loved ones. In 2019, we received funding to develop our MVP, and that's the product that we have live today. If we win the Cambina Grove Trails Award, that's going to help us to reach more clients across the country and to include palliative care content to help our users. We believe that senior living through end-of-life planning should be and can be a positive experience if you understand your options. We'd like you to help us to reach more users and communities with our innovative product.
All right. Thank you. 10 minutes of Q&A starts now.
Thanks, Margie. This is Matt. That was a great presentation, and I think it's a real problem area that I've seen family members go through, and I know friends have gone through. So interesting product. And I guess I'm just curious how you vet the institutions that are on the platform in terms of quality and affordability. Is it more of a directory where any institution can list their vacancies, or are you kind of providing guidance to the patients that are using the platform?
So what we do is, I was an adult child. So you go online and you vet the information. So we do that ourselves. I have advisors in the elder care management community that actually told me how to search communities. I did it for them. That's how I learned how to do it. And we will continue to develop our process. If we win this competition, that will really help us solidify the process for vetting all of our communities. But no, we're not a listing, we're curated. So we review all of the reports that are online, and we look into all of the information before we allow providers to join our featured communities.
Also, there is a certificate for the facility. Each of the facility for their care level is accessible along with the link to the information about all their past issues or write-ups they might have on the site.
Great, thanks.
Hey, Margie, I see a lot of potential with what you are offering, and I'm wondering if you have any plans to expand out beyond the senior community. So for instance, in the cancer community, sometimes we need to find, cognitive rehab or, independent hospice centers that offer palliative care, and directories like that would be invaluable to be able to tap into while I'm sitting on the couch and not feeling well.
Yes, when we developed this idea, the vision has always been and will continue to be develop all of the different options. We're senior living options. So our first product, our MVP, is the communities. That's where we saw the first pain. We are trying to help reduce the cost in senior living care. And the best way to do that is to get rid of referral fees. Costs so many thousands of dollars for communities across the country and small business owners who are doing some really great care. We currently have tested a vendor portal. So that's coming really quickly. As soon as we launched Golden Sherpa, right after that, I had wealth managers, case managers, geriatric case managers asking us where their part was in the Golden Sherpa platform. So yes, it's coming.
Margie, how often do you refresh the vetting? Things change rapidly in communities based on management changes, personnel changes, and a lot can go south in a really short period of time. So how often do you refresh all of the communities, the vetting?
So we're going to do that annually. As we build Golden Sherpa, one of the things that I've heard here, and I think is so very important, is to have that community engagement. So we're going to do a survey for the clients. It's a blind survey that will go to all our providers on our platform. If you take a survey, if you take a tour through the Golden Sherpa platform, we send you a survey. Then we send it to you again in 6 months, because usually when you're in a community, it takes that long. And then we send it annually. And each Golden Sherpa community will get a little Golden Sherpa seal of approval as we go through that process. And you know, this is good information for not only the users, but also for those community owners, because they need to know what that tour, how that happened in the tour, and why did somebody not choose their community? Does that answer your question?
In addition to updating, in addition to updating the quality piece, I'm also interested in how you update the access piece, because that's another thing that changes really day to day and week to week, whether folks have openings. So how are you pushing that?
Well, that is one of the most important things about Golden Sherpa and why we work with, why we're curated, honestly. We want to work with providers of service who are interested in updating their information. So we can see when a provider is active or not on our platform, and all of that information is updated by the community. I've talked to, we have large communities and we have small communities on our platform. And they have community engagement officers at larger communities, and it takes very little time for them to go and update the Golden Sherpa platform so that they can let everybody know they have availability. And we can also show when they don't have availability. So that's all part of the process.
So in addition to regular surveys and annual updates, knowing this community as I do, there are events such as, you know, certain problems that are identified on inspections by the Department of Health and things like that. Also personal experience with my mom. She was in a very nice place that was purchased by another organization that really was one of the worst organizations in the country. And so we weren't involved in anything like Golden Sherpa, but it would be very important that you have some kind of process that responds to changes, not just the calendar on you know, what's going on for your family member.
Well, again, we are not a listing and we're not a directory. People pay, communities pay us a monthly fee to be on our platform. And with that, we will be doing checks constantly as things change, because yes, you're right. I've met people in communities, and just the 2 years that I've been working on Golden Sherpa, they've moved 3 times. This is not an uncommon occurrence. And that's why it's so very important to give providers of service an opportunity to engage in one spot. And it gives those social workers and those case managers an opportunity to go to one place and get the most current information. And so we do that with Golden Sherpa. But as we go and expand across the market, I'm sure we will be tightening up how we do that. And we're early days, but I think we have a pretty good grasp on it today.
Thank you.
Are there ways for people of communities like LGBTQ and people of color and so forth to insert that into the search and have that be a part of ensuring that they're comfortable and that they're able to get culturally appropriate settings?
Absolutely. So one of the really great things about our platform is it's going to grow. It's going to evolve. And one of the most, when we talk about inclusivity, we have people who today, I got an email, Margie, do you have any communities that have an Indian owner for my brother? And people who, you know, we all know that the LGBT community, they may be, many of them, you know, they have to change when they go into senior care. And we don't want that. So we're looking for communities that can help support and talk about that for everybody across the country. Actually, that's one of my, I'm looking for those communities. So if you know anybody after this, let me know.
Just from the technical perspective, it is embedded in the platform. So if you look at things that you can search on, and those get added as we expand across. So there is a lot of way to search the information and get to exactly what you're looking for. And that's part of the education on the consumer part also, because I didn't know coming into it all the different things that you need to look for to care when you're looking for a senior living arrangements.
1 minute left. Any other questions? All right.
Well, thank you.
Margie, thank you. Okay, last up, our last company, we've got Parrots. David, go ahead and get.
Hello, can you hear me?
We can hear you.
Yes. Okay. Can you see my screen?
We can. Perfect. All right. Go ahead and start your slideshow and start in 3, 2, 1. Go for it.
Hello, I am David Hoja. I am the founder and the CEO of Parrot Inc. And our mission is empowering people with communication and mobility challenges to be connected with the world. There are many people like Stephen Hawking out there, and we do believe they are just missing accessible technology to be the next Stephen Hawking, the next engineer, designer, whatever they want to be. They're only just missing accessible tech and care. And that's why I started my company and I assembled my team. I have a background in mechanical engineering with over 10 years experience in robotics, drone, and medical devices. Alina Klov is our COO from Harvard Kennedy School with great experience in business and legal and accessible technology. Our CTO, he finished his undergrad from MIT Electrical Engineering and with over 25 years experience in telecommunication robotics. And even our scientist also from MIT she actually just finished her master's a few months ago. And we have also a great advisor like Dr. Rory Cooper. He is a veteran and also a wheelchair user and professor at University of Pittsburgh. Many others, including Steve Sailing, one of the people who built a smart nursing home, even speech pathologist Katie, even Nancy Frady, the mother of the founder of the Ice Bucket Challenge. So let me introduce our friend Steve. He was a great landscape designer, but in 2006, his life completely changed. And eventually he lost the ability to communicate, even to walk, and even to speak to his own son. But he has a great spirit by saying, ALS took my voice, but not my soul. So what's the problem here? People like Steve, they're facing a lot of challenges and they need really intensive care. And not just that, they have ineffective communication and basically also losing their independence. And there are many people like Steve out there, like ALS, multiple sclerosis, cerebral palsy, and other neurological disorders. And we're talking about over 190 million worldwide. In the US, we're talking about around 24 million. The problem not just for the patients, also for nursing homes and even special needs schools. So how to manage large group of patients and the cost of living for assisted living, for example, with someone like ALS, it's going to be over 200K per year. So that's why we are here. We built Poly, which is a social assistive platform, which consists eye tracking device can be mounted to any wheelchair or bedside. And the good news here also, it's compatible with all ability switches and any operating system like Windows or Android or iOS. So what are we providing? First, we have control, this including 360 computer vision, that plus smart navigation and smart home. But the main thing here is communication. We have state-of-the-art communication, which is much faster than any current assistive devices, because we have prediction system also this is in real time, because we understand what's happening around them and how are they interacting, even we understand their body language and facial expression. And the third one, which is caregiving, we provide also telecare solutions, especially to help the caregivers. So here's our first generation. The first generation here, you can see Steve, he's using our software with a tablet, and we have our hardware can be mounted just right into his wheelchair. We got into our devices to many users, and they're using our devices. Some people, they said it's super damn cool, and people are happy. The patients, even the caregivers, For example, here, one of the patients with the spinal cord injury, she said this is gonna help a lot, especially in home care. So here's some other use cases. For example, our device can understand simple things like from understanding what they need, like if they need a bottle of water, or even like what's happening during the day, and say sentences to communicate with others. Even like here's another example in nursing home and how to communicate more effectively with the caregiver or the nurse. And even like bedridden can do virtual communications. And even this is the second generation, including remote monitoring. This is going to be very helpful for people with very severe conditions, specialists with ventilators, or they need really intensive care. So the nurse can check on them all the time. Even one of the things we are implementing here, understanding the disability progression over time, because this is really important data, especially there's a lot of missing data between each visit, and we actually following holistic data approach with active and passive monitoring here.
All right, David, that was 5 minutes.
Oh, okay.
All right. Thank you. Do you have anything left? I don't want to cut you off too much. Do you want to have a final closing 10-second thought?
Yeah, I just we are working many partners, including like Novartis and many others, and would like to join us in our mission. Thank you.
Thank you. All right, 10 minutes, Q&A, judges.
Quick question, David. What are the security protocols? And you don't need to get technical with me, but just can you describe for me how to prevent hacking? Because it's such a powerful assist. It's such a powerful device. My concern is that if someone with ill intent was able to get in, it could be disaster, right?
Yes. Actually, our CTO, he worked with security and telecommunications for 20 years. So one of the things we care, patient data, of course. And one of the things, everything is here is HIPAA compliant, and everything is encrypted. So we care about that, and this is like one of the first thing we care. So that's one of the things we really care about that.
Hi, David. Thank you so much for this presentation and really innovative product. I enjoyed learning a little bit more about it today and reading about it prior to today. My question really is about the scalability of this and the pricing model. Can you talk a little bit about your pricing model and your go-to-market strategy?
Yeah, so right now we have over 55 users who are using our devices with the first generation. And we got all these through partners from nursing homes, hospitals, and speech pathologists who help us to reach all these people. And what we offer right now is limited offer, which is $1,800 plus the monthly fee. That's what we offer, but eventually we want to be like be covered by insurance. And we actually prepared our insurance filing to be by January. In 2 months. We are submitting our case. So that's something we are looking for to be basically with nursing, assisted living, even like we have the veterans. They have large community with disability like multiple sclerosis, ALS, and other conditions.
Thank you.
So are you?
Thanks for the great presentation. Oh.
Go ahead, please.
I was just going to say, we'll flip for it. Go ahead, Mary Kay.
Yeah, I was, so I'm a rehab doc. So, I mean, it would make perfect sense to me to have, you know, somebody who has a new neurologic injury or something, or is admitted for an progression of a disease, have training and have everything set up with a system like this in the rehab setting, and then have people essentially discharged with it, you know, as a way to manage their, you know, their life post-disability. So are you working directly with, you know, like the provision of therapy for people with these diagnoses?
So we work with nursing homes, and even we work with Washington State University and Steve Gleason Institute of Neuroscience.
Okay.
So we got a lot of feedback from the doctors and street pathologists, nurses. And then this is the nursing home in Boston, Florence data in Boston. So we work with, and even we have a nursing home in Spokane as well. So we work and get all the feedbacks from obviously from the patient all the time, but also from their caregiver, the nurse, their therapist, all the time to improve. And one of the things I want to mention, we won Novartis Assistive Technology Award a few months ago, and they are helping us to advance assistive technology for people with multiple sclerosis. And that's, they are helping out a lot from a medical perspective and what we need to care from, obviously from security, also from what they need in terms of data and other things.
Thank you.
It seems as though one of the benefits of this, and also possibly a downside, is that it's intersecting with a lot of other technology. And I'm just interested in how much other technology does somebody have to already be using to make this kind of work and fit in? And is that pretty standard for folks at this stage?
Yeah, so one of the things, if you can see, for example, here, we have different people here, like in this photo, you have this based on their disability. This need like the software, the tablet, also the hardware. This one, it's only the tablet here, and that's it, because he can have more ability to speak and move around. So one of the things, our device is basically a plug and play device. So you can just install the device, then the device will be just play with the device. And then you can start communicate and talk with caregivers. And also one of the things I want to mention, we implement customized machine learning because each patient is different. I'm not talking about just ALS, multiple sclerosis here. This is our focus right now, but we will expand. But our device can understand what they are looking for, even how they are communicating, how is their body language, how is their disability over time. And this all will be into effect, and how they're using now, using eye tracking, or they're using joystick. Based on their ability, our system and platform will make that easier for them.
4 minutes left.
This is Matt. Really interesting product, and I'm curious what it's like as a caregiver to interact with someone who's using the device and the platform. So I think you had mentioned there's a telecare component, and maybe that works remotely, but just curious if you can go into detail for us on, as a caregiver, how do we interact with it?
Yeah, for example, where is that? Here is this another one of the use cases here. This person, like in very severe conditions with ALS, like this is whether it's a nurse or even their spouses, or they can check on them. There's life monitoring if there's an attack, or they're choking, or there's something as emergency. That's the system will pick up, because there's computer vision, understand what's happening to them, if there is any disturbance or anything urgent, so the device can pick up and send alert to the caregiver. That's one thing in terms of emergency. This is one of the use cases.
Can you talk a little bit more about the longitudinal data and how that's going to impact future care? for these conditions?
I mean, you're talking about this one?
Yeah, like how is that being gathered? Where is it being stored? Like who's working with that, and how is that going to be made available in a usable form for future providers?
Yes. So right now, this is this one is under pilot, and we're still testing what is the best method to do. But we do passive monitoring, that you can just tell the device to passive monitoring based on what based on their physical ability and their body language, body ability. And then we see over time what's happening, like for example, today, tomorrow, and we see like, oh, they cannot move their hands, or they are better than yesterday, or it's getting worse. So these are the things will be all available for the doctors to check at any point and go back to see what's happening. But this is also one of the things we are working with Novartis to help us what's the main data that they need, because we are non-invasive. We're just, the device is just based on what we collect from voice, from also from the camera, from other sensors. So that's what we do. So, and then we'll give them basically a comprehensive report based on what they need.
30 seconds.
This might be a superficial brief question, but what has the feedback been about the parrot, about having a parrot on your wheelchair with you?
There are great feedbacks from the users. They're super happy, especially from to have a faster communication with their nurses and caregivers. And also the caregivers, they can check on their patients at any point, they have less worry about their patients because now there's a device to check on them. If they have anything, they will can pick up from emergency or even like at normal situations.
All right, that is time. Thank you for your presentation. And everyone, all of our attendees, all of our presenters, our trail finale finalists, all of our judges, thank you so much. We are just thrilled to have this group of people come together to advance these critical solutions. Okay, so what's next up? Next up, we are going to go ahead and end this meeting. Our judges will join us in a different link at 2:50 Pacific time. So judges come over at 2:50 Pacific time to deliberate. Keep an eye out for an announcement via email in about 1 hour or so to announce our winner for our trails competition, and a live recording will be included in our newsletter on Thursday at Cambia Grove. Again, this has been an incredible time. This has been an incredible journey for Cambia Grove and all of the judges, and we are just thrilled with all of the work thus far. Judges, you've got 5 minutes. I will see you at 2:50. Thank you all.
Thank you, everybody.
Thank you.